Hello, everyone, and thank you for joining us for this year's Wood Forum. On behalf of the University of Calgary and the McCaig Institute for Bone and Joint Health, welcome to the 2021 Wood Forum on Sports Injury Prevention. I'd also like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, as well as the Tsuut'ina and Stoney Nakoda First Nations. The City of Calgary is also home to Métis Nation of Alberta, Region number 3. Although this year's Wood Forum looks a little different, I'm so happy that we can still gather online and welcome a wider audience from Alberta and beyond. Thank you all for joining us virtually today. Now, first, a few housekeeping items. Before we get started with the program today, I'd like to introduce you to our online program, our platform. Below the video screen, you can view the event program and learn more about our speakers. Also, to the right of the screen, you will notice a Q&A box. If you have questions during the presentations, feel free to submit your questions by typing them into the Q&A box. Now, please note that the questions will be reserved for the Q&A panel until after all the presentations. Questions will not be answered between presentations. So if you see a question that you would like, that you like it in the Q&A box, well, you just need to like it or upvote it so that there is a greater chance that it will be selected. Our speakers will be happy to answer any general questions that you have, but they will be unable to offer specific medical advice. So please make a note of that. If you are experiencing or about to experience any technical issues, let's face it, we are still in COVID times, and I think we all know what that can mean. Please contact Maven Media at broadcast@mavenmediagroup.ca. In fact, you can see the information down below where there is a technical issues tab that you can also access if you're having technical issues. Or you can call 844-286-2836 to extension 3. Note the contact information is actually included in the reminder email that was sent to you this morning. Lastly, today's presentations will be recorded. The recording will be shared on YouTube and the McCaig Institute website after the event. Okay, so welcome. And a quick introduction of myself. My name is Lisa Bose, and I'm thrilled to be your MC for this year's Wood Forum. I'm the author of the Lucy Tries Sports children's book series, which inspires our next generation to be active and persevere. I'm also a physical education graduate and a parent of a teenager who I'm very pleased to share with you is actually taking sports medicine as an option in her first year of high school. And she is really loving it. And she's really enjoying coming home and taping her parents' wrists and ankles and thumbs. Sometimes it's a little tight, I do have to be honest with you, but she really is enjoying it. So I'm particularly interested in this year's topic, and I know that I'll be picking up some great insight into how to prevent my daughter from experiencing injury during her various sports pursuits. So thank you again for having me. Today's event will host 5 presentations from our expert speaker panel who will discuss the latest research in sport-related injury prevention and rehabilitation strategies. I am sure many of you here today have experienced a sports injury at some point in your lives. Maybe you've sprained your ankle while playing soccer. I can relate to that. I did both my ankles twice each, or maybe you've experienced an overuse injury from running and exercise. For those who have experienced injuries, you know all too well how injuries can drastically impact your mobility and your ability to participate in sports and recreational activities. Through the past 19 months of living in a pandemic, so many aspects of our lives have been altered. The pandemic has disrupted our work routines, our travel plans, our social gatherings, and it has changed our fitness routines and exercise activities. When gyms closed and group fitness classes were paused, many of us adapted and incorporated different exercise routines. But as we gradually return to normal, it is important to adopt injury prevention strategies to ensure that we can continue to enjoy our favorite activities injury-free. For example, skiing, right? The ski hills are about to open, I think, even as soon as this weekend. So there's a perfect example of getting back into those routines. Fortunately, there are people who spend their careers focusing on how to keep us moving. Amen. Today's Wood Forum is an initiative supported through the Wood Joint Research Fund, created by Dr. John and Mrs. Christena Wood, that is now carried on by their daughter, Dr. Donna Wood, in their honor. The annual forums are designed to bring the public and researchers together to discuss the impact of bone and joint diseases and injuries and learn about the latest cutting-edge research in the area. We'd like to thank the Wood family for their ongoing support and leadership with this event. Thank you. Before we start the program today, I'd like to welcome Dr. Stephen Boyd, a researcher and the director of the McCaig Institute for Bone and Joint Health. Dr. Boyd is a professor in the Department of Radiology in the Cummings School of Medicine, with joint appointments in the Schulich School of Engineering and the Faculty of Kinesiology. His research focuses on the adaptive changes in bone that occur following a joint injury or disease. But today, he's not here to talk about his own research, but rather to talk about the McCaig Institute for Bone and Joint Health and an exciting research study called the Mobility for Life Project. Dr. Boyd.
Thanks very much, Lisa. I would also like to thank, on behalf of the McCaig Institute, Dr. Donna Wood and the Wood family for their continued support of the Wood Joint Research Fund and their involvement in hosting the Wood Forum each year. As Lisa said, my name is Steve Boyd. I am director of the McCaig Institute for Bone and Joint Health. I'm a biomedical engineer, and I was musing as Lisa was introducing that I should have been paying more close attention to injury prevention in the past few years, where skiing and mountain biking has done me in a few times. So I'll be very interested to hear the speakers today. The theme of this year's Wood Forum is on sport injuries and injury prevention strategies. And as I was saying, it's a topic that many of us can relate to, and I'm looking forward to hearing from the speaker panel. I'm also here to virtually welcome you to the McCaig Institute for Bone and Joint Health. The McCaig Institute is at the University of Calgary. It's a multidisciplinary research institute that's comprised of basic scientists, orthopedic surgeons, rheumatologists, physiotherapists, radiologists, kinesiologists, and lots of different ologists and biomedical engineers, all working together to understand, prevent, diagnose, and develop new treatments for bone and joint conditions. Our researchers work on many different aspects of bone and joint health. And some of the key areas that we focus in are osteoarthritis, rheumatoid arthritis, osteoporosis, and joint injury. Our overall vision is to lead the improvement of musculoskeletal health for patients across their lifespan, from youth to seniors. And we do this through research and education. And our goal is to provide everybody with pain-free mobility through their life. Could I have the next slide, please? The Mobility for Life project is an exciting project that I'd like to share with you. It's led by researchers at the McCaig Institute for Bone and Joint Health. It was launched in 2019, and it's a long-term research study of how bone and joint diseases can develop and progress over time, so that we want to use this study to find ways to prevent, diagnose, and treat these diseases before irreparable damage occurs. To gather data for the research study, we need thousands of Albertans, both with and without bone and joint conditions, to participate. And so we invite you to participate, people listening to this talk. Once enrolled in the Mobility for Life project, participants will be able to complete annual health and lifestyle questionnaires, and they may be invited to participate in optional in-person data collection, where we can do things like medical imaging, clinical and laboratory testing. And we do this at various intervals over the next 2 decades, actually. So the information that we collect with this study will form a comprehensive musculoskeletal health database that will help researchers identify early indicators of disease and improve diagnosis and target more effective treatments. So I really encourage anyone who is interested to participate in this study and to go to the link that's shown on the slide here. It's at the University of Calgary, so ucalgary.ca/mobility-for-life. I'm not sure if you can read that small type on the screen. And again, I'd really like to turn our attention to this year's Wood Forum, which I'm excited to listen to myself, and I'll turn it back to Lisa to get us going. So thank you very much, everybody.
Thank you, Dr. Boyd, for that warm welcome address from the McCaig Institute and for sharing this exciting news on the Mobility for Life project. So we encourage you to please participate in that project. Now we will start the program with a presentation by Dr. Carolyn Emery, who will discuss targets for injury prevention in youth sport. Dr. Carolyn Emery is a physiotherapist and professor in the Faculty of Kinesiology and Cummings School of Medicine at the University of Calgary. Carolyn is the chair of the Sport Injury Prevention Research Center and is a Canada Research Chair, fellow of the Canadian Academy of Health Sciences, Killam Annual Professor, Christensen Fellow at the University of Oxford, and member of the Royal Society of Canada College of New Scholars. Dr. Emery's research program focuses on the prevention of injuries and their consequences, aiming to reduce the public health burden of injuries and their consequences in youth sport and recreation. Dr. Emery.
It's my great pleasure to present at the McCaig Institute Wood Forum. This morning, I'm going to focus on targets for the prevention of injuries in youth sport. In Calgary, as in many places around the world, we see high rates of participation and injury in youth sport. This leads to a significant public health burden. In Alberta, we expect 1 in every 3 youth ages 11 to 18 to seek medical attention for a sport-related injury each year. Lower extremity injuries account for 60% of these injuries, and of those, 60% are ankle and knee joint injuries. The greatest proportion of these injuries occur in sports such as basketball, ice hockey, soccer, skiing, and snowboarding, where we see high rates of participation as well as high injury rates. The consequences of injury in youth sport can also be significant, and these may include reduced levels of physical activity, overweight and obesity, psychosocial consequences, post-traumatic osteoarthritis, and the economic burden associated with injuries in youth sport. Sport-related injuries in youth are predictable, and therefore they are preventable. When we talk about prevention, it's across the continuum from primary prevention, where we're targeting youth who are healthy and participating in sport to prevent injuries from happening in the first place. Secondary prevention, with a focus on the prevention of injury recurrence, perhaps in those that have had a previous history of injury. And tertiary prevention, whereas clinicians, we work in rehabilitation to prevent consequences of injuries in youth sport. I challenge you to think upstream towards primary prevention, where we can have the greatest public health impact in reducing injuries and their consequences in youth sport. When we do research in sport injury prevention, we rely on surveillance to inform the extent of the injury burden in specific youth populations, for example. And as well, we can evaluate risk factors for injury in youth sport, which then lead to the development and evaluation of prevention strategies. Validated injury surveillance, in this case, led by the Sport Injury Prevention Research Center at the University of Calgary, relies on strong partnerships with community clinical partners, as well as sport and school partners, to ensure the efficiency of the injury surveillance system in evaluating prevention strategies in youth sport. The targets for prevention are across rule changes, equipment, and training strategies. And I'm going to share with you some of our research that has informed best practice and policy in the prevention of injuries in youth sport. This research relies heavily on strong partnerships with sport and school partners. Our injury surveillance system we call SHRED injuries, or surveillance in high school and community sport to reduce injuries and their consequences. As with any research, we require consent to participate, collection of specific exposure data or participation hours and practices and games, for example. And then we collect injury data out in the field and at the ice hockey rink, for example. It relies on study therapists as well as physicians to assess injuries following their identification in the field. Our injury surveillance data feeds back to clinicians to make the best decisions for return to sport, return to school, as well to our stakeholders so that we can have evidence informing best practice and policy in the prevention of injuries in youth sport across schools and community. To share with you an evaluation of policy in youth ice hockey, we've been doing research for over 15 years, and evidence informed a policy change to disallow body checking in 11 and 12-year-old games across Canada. When we had the opportunity to evaluate this policy change, we found a significant reduction, 50% reduction in all injuries and a 64% reduction in concussion alone following this policy change in 11 and 12-year-old ice hockey leagues. If we translate that to the national impact, we see an estimated reduction of over 6,000 injuries in Canada and 11 and 12-year-old players alone following this policy change in 2013. This research informed further policy change regionally and provincially in older age groups. And in one of our studies, we evaluated the reduction of injuries and concussions in 15 to 17-year-old players following regional and provincial policy change, disallowing body checking in non-elite levels of play in 15 to 17-year-old leagues. Non-elite levels includes 60 to 70% of players in this age group. And what we found was a 65% reduction in all injuries and a 51% reduction in concussion alone. This translated to an impact and an estimated reduction of over 7,000 injuries in 15 to 17-year-old players across the country if all provinces had policy disallowing body checking in non-elite levels of play. Moving on to training strategies. Neuromuscular training is a well-known strategy to reduce the burden of injuries in youth team sports. Through a 10 to 15-minute warm-up, including aerobic exercises, strength training, agility and technical components such as jumping and landing skills, as well as balance training, we see a significant reduction in injuries across multiple sports. Neuromuscular training evolved from rehabilitation strategies, for example, following anterior cruciate ligament injuries in youth. They became more well known in sport performance, in team sports, and then further became part of a standard of practice warm-up, targeting the prevention of injuries and improvement of performance in athletes. And then more recently in physical education classes, targeting a more global reduction in injury rates in youth. Sharing with you a randomized controlled trial where we evaluated neuromuscular training in indoor soccer in Alberta, where we see a significant reduction in all injuries of 38% and an impact in injuries across numerous injury types, such as ankle and knee injuries, as well as concussion. When we teamed up with our very own Dr. Deborah Marshall, the McCaig Institute, a health economist, we're able to do an economic evaluation alongside our evaluation of prevention strategies in youth sport. And in the context of neuromuscular training in youth soccer, we see a significant reduction of injuries, as well as a reduction in costs associated with those injuries in this cost-effectiveness plane. If we evaluate and interpret the reduction in Alberta, if neuromuscular training was part of standard of practice across all leagues in youth soccer, we would save over 5,000 injuries and over $4 million in healthcare costs in Alberta in one season alone with neuromuscular training in youth soccer. Further to that, we did a large randomized controlled trial over 3 years in junior high schools, now targeting 11 to 15-year-olds. These students are participating in physical education, and neuromuscular training was a warm-up strategy implemented in their physical education program. What we found with implementation of neuromuscular training and physical education was a significant reduction of all injuries, lower extremity injuries, and medically treated injuries. However, this was only in female students. When we looked at the boys, we saw no reduction in injury rates across these definitions. We think this may be related to exercise fidelity in boys that are 11 to 15 years old in a non-sport specific setting. So that relates to the quality of movement in completing the exercises in the neuromuscular training warm-up. This was not seen, this differential effect, in sport-specific settings across numerous randomized controlled trials in team sports, where we saw an effectiveness across boys and girls. Further to this, we've translated to scaling up workshops for teachers, coaches, and clinicians across Alberta. A shout out to Carla Vandenberg, who is our knowledge broker that has led this work with the support of the Alberta Bone and Joint Health Strategic Clinical Network. We've delivered over 128 workshops to more than 2,200 participants in Alberta. We've developed resources. They're available on our website and inclusive of videos that are available across multiple sport-specific and physical education contexts. Shred Concussions is a pan-Canadian program of research that's funded through the NFL Play Smart, Play Safe program. While it's focused on concussions, we use injury surveillance to be able to identify and evaluate prevention strategies for all injuries in youth sport. This is supported also through the Canadian Institutes of Health Research and other funding bodies. We are targeting 6,000 high school sport participants, participating in more than 12 high-risk injury sports across 5 provinces. We will have the opportunity to evaluate prevention strategies across rules, equipment, and training targets. I'm really excited to tell you about the Shredmobile. If you haven't seen it yet, this is our mobile unit supported through a Canada Foundation for Innovation infrastructure grant. We are scaling up our injury prevention research program as well as our knowledge translation program across Alberta and beyond. We are partnering with rural communities as well as Indigenous communities to support a greater public health impact in the prevention of injuries and their consequences in youth sport. To shred injuries, we need to move upstream towards primary and secondary prevention to have the greatest public health impact. We need to continue to scale up our validated injury surveillance to evaluate injury prevention strategies across rules, equipment, and training. We wish to inform best practice and policy in the prevention of injuries in youth sport with a lofty goal of reducing injuries in youth sport in Alberta 25% by 2025. A shout out to the incredible team at the Sport Injury Prevention Research Centre and the Faculty of Kinesiology at the University of Calgary. This team has supported much of the work that I have shared with you today and beyond. I want to thank as well our community partners across sport, schools, and clinical partners that support the work to inform best practice and policy in the prevention of injuries in youth sport. Of course, I need to thank my kids who led me to make injury prevention in youth sport a priority. Thank you so much for your time this morning, and I really look forward to the panel discussion to follow.
Thank you so much, Dr. Emery. Such important information and research for our next generation to ensure that they do have good long-term health outcomes. And I will be ensuring that I reiterate to my young daughter how the warm-up is key, just as a first thing to start with that. Next, I would like to welcome Dr. Nicholas Mohtadi for a presentation on how to reduce injury risk when returning to pre-pandemic exercise activities. Dr. Mohtadi is a clinical professor in the Department of Surgery, Cummings School of Medicine, and an adjunct professor in the Faculty of Kinesiology, University of Calgary. He is a clinical epidemiologist and surgeon scientist who has been operating in the field of sport medicine and arthroscopy for 31 years. He's participated as a team physician for the Calgary Flames and for multiple international sporting events, such as team physician for the Canadian Olympic team in 1996 and 2002. Dr. Mohtadi is currently the medical director of the University of Calgary Sport Medicine Center and director of the Acute Knee Injury Clinic. Please welcome Dr. Mohtadi.
Thank you very much for this opportunity to deliver a message today that hopefully will be useful to everybody involved. I'm going to talk about from pandemic to epidemic. Now, normally I would be giving a disclosure, a financial disclosure. But it turns out my only disclosure today is that I have been affected by the pandemic too. And I hope that you haven't deteriorated to this extent. I'm going to talk about things that I think relate to this issue of how the pandemic is affecting us. I'm not going to talk about it specifically, not use too many numbers, but I do want to talk about some principles. And the principles are related to entropy, biomechanics, the tissues that are involved, the epidemiology of injury, which we've heard about already, and some evidence to support this. And then finally, with a discussion about how I think we should prevent these injuries. So one might ask, what about entropy? Well, my father used to teach a course in thermodynamics at the university, and he used to tell us around the dinner table about entropy, and I thought this was completely irrelevant to me as a teenager. But it turns out we're all involved in this universal process of degradation, running down, trending towards disorder, and these are things that relate to our aging and disuse. So to explain entropy a little bit more clearly, if we drop a cup on the floor, it smashes into multiple pieces. We can't take those pieces and drop them and form a cup. It requires a lot of energy to do so. And this is a universal law that we cannot change. And during the pandemic, we are tending towards disorder. If we look at the biomechanics and view these young kids playing in recreational ways, they are loading their tissues normally. This load, the biomechanical load through their joints and muscles, really is one that helps them grow and develop and get stronger and more resilient. Whereas as we go to a more elderly population, these biomechanical loads can lead to damage and problems and require us to go from a sport like running to biking, or in my case, even to e-biking. Next slide, please. An old friend of mine developed this theory, and he calls it the envelope of function theory, where the idea is that we live within a zone of homeostasis on the bottom left of this graph. And as we move towards the top right, we exceed our zone of homeostasis through increasing the load on our tissues. And eventually this leads to failure. And this failure can occur with an intense load on the left side or with respect to increasing volume or frequency. It's much easier to look at this from the standpoint of our happy zone on the lower left, what we can gain through training if we push ourselves through a reasonable threshold. But if we go too far, this will result in injury. So I want you to keep this graph in mind. I'd like to address all of the tissues that are involved in our injuries, whether it's from bone to the meniscus in our knee. If we look at what happens when we enter the pandemic and we start reducing our activity, our bone becomes more porous. In other words, it has more holes in it. The bone becomes weaker. and it is susceptible to injuries such as what happened last weekend to this professional footballer, where he developed a stress fracture in his foot. The same thing can happen to our tendons. If they get inflamed, they are weaker, or if they weaken over time, then they can rupture. So we can see injuries both from an acute standpoint and also from an overuse standpoint. Now, when it comes to muscle, we typically think that as we work out, we can get stronger, our muscles will get better. But if we've had a previous injury like this athlete, then recovering from the injury results in weakness in these muscles, and they become susceptible to injury despite doing something that he may have done thousands and thousands of times. With respect to ligaments, the picture on the top right is a normal ligament with the wave pattern that allows us to be resilient in our activities. But despite this, we can do something again many times and then rupture this ligament, which results in changes in the joint and damage to the joint over time. If we think about the discs in our backs and we do an MRI, we can see a normal disc or we can see a damaged disc, as we see at the bottom here. The same thing occurs to the menisci in our knee. And even though the meniscus might still be present, if we do an MRI of this knee, it'll show that the meniscus is damaged and torn, where in fact this is really an effect of arthritis. So all of these things are impactful as we move from the pandemic forward. So if we go back to this graph, what is happening in the last 19 months is that everything has shifted to the left. Our happy zone is much smaller. The threshold for training is less. And most importantly, the threshold to injury is much less, with a lower load or intensity resulting in injury, or a lower frequency or volume of activity resulting in injury. If we move on to the epidemiology of injury, and we've heard a lot about that already, but two of the most important factors that would lead to injury are a prior injury, such as in our quarterback. He had a bad injury to his ankle and now he's injured his muscle, or a change in the activities that we do, change in volume, intensity, or technique, for example. And this is an example of what happened earlier this year. The Saskatchewan Roughriders returned to play, and on one day, 4 of their athletes tore Achilles tendons, and they hadn't even played a game yet. When the gyms closed and the pools closed, running outside seemed the only option, and yet within 3 days, a runner would start getting Achilles tendonitis and was injured to the point where they couldn't continue. And then what's left? So if it comes to prevention, which is the focus of this forum, we have to consider different strategies for acute and overuse injuries. And Carolyn has nicely described many ways that her research has resulted in a reduction of acute injuries. The same principles, to a greater or lesser extent, can apply to overuse injuries as well. If we're going to prevent injury, we have to understand how to do that. And there are certain risk factors that we can do nothing about, such as our age, our sex, and the genetics that we carry with us. So as much as I would like to change the strong family history of arthritis that I have in my genes, there's nothing I can do about that. However, the modifiable risk factors, such as the type of activities that we do, so going from running to e-biking, the delay returning to sports so we reduce our risk there, or adjusting the intensity and volume of training that I'm sure Matt is going to address later, are the ways that we can prevent injury, whether these are acute or overuse injuries. So this is what I do on a daily basis. I fix torn anterior cruciate ligaments. And if we follow our patients over time, which a lot of us don't always do, we find that the injury rate continues to go up. 2 years, 10% of our patients have re-injured one or the other knee, and by 5 years, 20% of our patients. Well, these are alarming statistics that our research has demonstrated that before really weren't paid much attention to. So what it boils down to is if our patients that we operate on are going to avoid injury, then we have to understand how rehabilitation will reduce that risk. and tell patients that it takes 13 months to get back to their sport, not 6, and that most people actually don't get back to the same level of activity. And with this knowledge, we can move forward and advise people so they don't have devastating second or third injuries to an already reconstructed knee. So what this boils down to in terms of prevention is restoring a balance. And I think we can all reflect on the last 19 months where the balance in our lives has not been met. And now that we pull through this pandemic, we have to make sure we apply these principles of entropy, biomechanics, understanding injuries, and maintain a balance going forward. So in summary, the pandemic has really been a perfect storm. If we understand these principles that I articulated, then hopefully we can adjust and improve and prevent overuse and acute injuries. But ultimately, it's about restoring a balance for each and every one of us on an individual basis. And thank you very much for your attention.
Thank you so much, Dr. Mohtadi. So important that we think about that, especially for all those athletes with those so devastating ACL injuries. Next, and this is really great that Dr. Jordan is now coming up next, because I will first let me welcome Dr. Matt Jordan, who will discuss the importance of muscle strength in returning to performance after knee injuries. Dr. Jordan is an assistant professor in the Faculty of Kinesiology at the University of Calgary. He is also the Director of Sports Science at the Canadian Sport Institute, Calgary, where he helps lead interdisciplinary performance teams that support Canadian Olympic athletes. Dr. Jordan is a specialist in player health and performance and has been a performance scientist working with elite athletes over 6 Olympic Winter Games. His research focuses on neuromuscular adaptations to resistance training and knee injury, re-injury prevention. A key method in his research is the development of neuromuscular testing techniques that can be used to monitor recovery after knee injuries, to forecast recovery and improve rehabilitation. Please welcome Dr. Jordan.
Thanks very much. It's great to be here. I am especially excited to present now after Dr. Emery and Dr. Mohtadi, just because maybe I can shed some light on some ways that we can improve outcomes after injury, especially amidst this COVID time. I just want to acknowledge our research team and all the individuals who help us, especially the Canadian Sport Institute Calgary, which is one of 4 Olympic training centers in Canada. And we are, mission is pretty clear. We try to get these athletes to the podium healthy and safe. And when they get injured, we do everything we can with a multidisciplinary team to support them back on their journey to recovery. And I want to shed some of that here today in the presentation. So where are we heading? Well, we're going to talk first about why this why our research program exists and why we do what we do. I want to talk about how we measure muscle strength. I want to give you a couple reasons why this matters, and then I want to kind of end by maybe helping you think a little bit outside of the box of some new research that's been coming about how we can restore our function after ACL injury and get ourselves back to performance without that second injury that Dr. Mohtadi was talking about. So quickly about our research program, I can explain it like this. Imagine taking your car to your dealership and they hook up all the computers and they tell you what's wrong with your engine. That's kind of what we're doing with an athlete who gets hurt. And so we bring our athletes up after their injuries. You're seeing a video here on the screen of a elite alpine ski racer who is at 4.5 months post-surgery, and on the top still shot, and on the bottom 7.5 months post-surgery. And you see us here measuring her limb symmetry in a vertical jump. This is just one of the tests that we do in our lab. We also try to use these data to inform sort of recovery profiles, so we can start to figure out, when an athlete is more prepared to get back to a high-risk activity. And at the end of the day, trying to target better rehab and better retraining. And there are the videos running on a click. So it's kind of timely, I think, because the ski hills opened up in Alberta. So I think Lake Louise and Norquay opened up. And this is a sport that I've spent a great deal of time in, alpine ski racing. And A lot of times when you talk to a ski racer or somebody who skis, ACL injury sort of sounds like getting your wisdom teeth pulled. Every other person seems to get it. It's almost normalized. But what we know based on our studies is that these injuries are severe. And very often when these injuries happen, they are more than just, a simple ACL rupture. There's all kinds of things that happen to the knee joint that really do get in the way of the things that we love. And moving sort of forward with our research program, I just want to acknowledge Drew Lawson, who's a recent graduate from our master's program at the Canadian Sport Institute, Calgary. And the video that you see here on the screen is an example of a freestyle skier who's coming back after ACL injury. And Drew was looking at how these athletes landed after knee injuries. And it kind of gives you this example. You see this probably about maybe 10 months post-surgery here. Drew's instructing him to step off the box and land in a stacked position. And you can clearly see that that's not happening. And, what is the consequence of this in being sort of insufficiently prepared for return to sport? Well, it's oftentimes what my surgeon friends have called the regrettable case. I share this video with permission. It's a former alpine ski racer from Canada who was about 13 months post-surgery after an ACL reconstruction. And you see him going for an awful tumble, and he is holding the other knee at the bottom as he sort of comes to a halt. And that is, I guess, when we say the regrettable case, so to speak, it's that high incidence of not only hurting the same knee again, but the other knee as well, oftentimes with skiers, that we are trying to prevent. So what can you do to avoid this? And that's our second stopping point in the presentation here today, is to talk a little bit about muscle strength and how we measure it, because it's important. So I often say a little sort of tagline I say is that if you want to manage the uncertainty around coming back after an injury, you can't change what you don't measure. So there are things that we know that can help you prevent that second injury. But if you're not tracking them and you're not monitoring them, it's kind of like putting money into your bank account, hoping that you'll have enough to retire there one day. You've got to track these things over time. And that's sort of the key thing about why muscle strength matters so much. And, Dr. Mohtadi did a great job of giving us an idea about how our injury rates go up. Our risk for injury goes up after, that first injury. And I want you to get a bit of a visual. This is actually based on, let's say, a relatively good approximation of what the risk would be for an elite alpine ski racer to suffer an ACL injury. And I'm talking about that first one. So imagine you take the bucket on the left, you reach in there. If you get a red chip, it's an ACL injury. If you get a blue chip, you're good to go. Sometimes I think about it like the chances of rain. And the bucket on the right side is how much the chances of rain goes up after that first ACL injury. So what we know is that after you've had that first knee injury, you're reaching into a bucket with a whole bunch more red chips. And our goal is to bring that risk profile down to a place where it's more manageable. Dr. Mohtadi touched on a very important thing, which is, can we delay our return to sport until we've had sufficient healing, sufficient training to help us get back? And another big piece about this is getting our muscles strong again. So in our lab, one of the ways that we will measure this is we'll put an athlete in a dynamometer. We will have them do what's called a maximum voluntary contraction. You can see one of our skiers in a dynamometer right now, and one of our old strength coaches is yelling at her to push as hard as she can. And from here, what we can measure is the strength of the muscle. And that's shown here by that little red dot. But think about an injury that might happen in ski racing. It's far more complex than that. So a video on the bottom is another way that we evaluate the strength of our athletes. Here you see this athlete doing a vertical jump with a little bit of extra load, which is a really nice way to measure their strength. And if we think about the mechanisms of ACL injury in ski racing, we also know that it's more than just, these sort of strength capacities. These injuries happen in a fraction of a second. So not only are we looking at how strong an athlete is, but we're also looking at how fast they can make force. And again, if you imagine this, you come into the lab, it's like we're hooking our computers up to the engine of your car to diagnose where we might have a deficiency in strength. And then we can do what we do best, which is provide you with the exercise and the rehab and the training to help mitigate those deficits. So that's a little bit about how we measure this. And now I want to talk a little bit about why our muscles matter so much and why strength is so important. So first of all, if we take a look at the knee joint, and this is just a little sketch of your tibia and your femur, and going back to that video that you just saw of the ski racer landing in the back position, and nice little video of how the ACL might rupture. Your muscles are your ACL's best friend. Our muscles are the things that we have that we can control, with our brains, and these are things that can provide support for our ACL in the event that we have these high energies that come in from the outside environment and load our bodies in ways that we don't want. And one just example here would be the hamstrings. They're the muscles on the back of your thigh. There are exercises you can do to train your hamstrings. And there's a decent amount of evidence to suggest that if you can get your hamstring strength to go up, this is actually a good way to mitigate the risk of an injury. But here's the interesting thing, and Dr. Mohtadi talked about this in his presentation. 13 months, he mentioned that as being like how long it might take for athletes to regain their strength to get back to sport. This study was actually on our elite alpine ski racers who are on average 2 years post-surgery. And what you see in red is the ACL injured limb. And this is looking at their strength compared to the non-injured limb in blue and compared to the limbs of non-injured skiers in gray. And what we found is that in many of our skiers, even many years after an ACL reconstruction, they still have deficits in strength that potentially put them at risk for a second ACL injury. It just comes back. You can't change what you don't measure, and exercise is the medicine here once you know the problems are there to help mitigate the issue. Another example that I wanted to share that Dr. Mohtadi also touched on is there are all kinds of other comorbidities that happen when you get an ACL reconstruction. So, for example, sometimes the surgeons will take a piece of your one of your hamstring tendons to reconstruct a torn ACL. And this is a really neat ultrasound image from Nate Morris, who is one of our graduate students, where he looked at the effect of taking these tissues out of our body and what it does to our muscles. And on the bottom panel here of the screen, you can see on the right side, this is an athlete who's received that type of surgical procedure. And at 12 months post-surgery, there's actually no evidence of the muscle at all. So up here in the top panel, you can see in red that middle muscle, there's actually 3. Take a look at the bottom picture in the right-hand corner, and you'll see that there's actually no muscle there. So that's another example of what happens to our bodies and our muscles after we have these types of injury. Okay, moving on as we start to wind down the presentation, here's a great study that followed active individuals who'd suffered ACL injury, had a subsequent ACL reconstruction. And I love this tweet from physiotherapist Mick Hughes. It summarizes the paper beautifully. And it says, for every 1% increase you can make in the limb symmetry index of your injured side and getting your quadriceps strength back to where it would have been sort of normalized to the other side, there's a 3% reduction in that future risk of a re-injury. It's a great example in the research about how and why strength matters so much. Okay, in our final stopping point, I want to actually pivot a little bit from strength, and I want to ask a question. Are you a Cadillac, and I'm talking about a nice squishy 1984 Cadillac, a soft ride, or are you an Audi S4? And you can imagine the suspension in these two vehicles are drastically different. The Audi S4's got that tight suspension that can help you turn those corners, deals with the high energy very well. And the squishy Cadillac is comfy to ride, but you don't have that suspension. And here what we see are videos from 2 athletes. The one on the left is a young female skier, development level at 7.5 months post-surgery. And the one on the right is of an elite alpine ski racer who's 7.5 months post-surgery after ACL reconstruction surgery. And this athlete has probably a decade or more of training underneath her belt. And you don't have to be a biomechanist or a physiologist to see that these 2 athletes are jumping very, very differently. And it is this that is another great study that recently came out. This study was done on almost 1,400 level 1 athletes in Europe. The study was conducted out of Ireland. And it was interesting to note that the athletes who went on to suffer a re-injury after ACL reconstruction were way more like the squishy Cadillac. And that's that sort of faded silhouette that you see in the background is how the athletes who fared well looked. So they were stiff suspension and able to do a vertical jump or a change of direction maneuver like that Audi S4. Whereas the athletes who fared poorly after an ACL reconstruction surgery, they look like the darkened silhouette that you see on the front of the image. They were squishy and couldn't generate that whole body stiffness, which is so important to help us recover after these injuries and get us back to the things that we love to do, back to health, and eventually back to performance. So with that, I just want to wrap up and say that, our goal is to help athletes get back to the things they love to do, get back to performance after injury. Strength absolutely matters. The science shows us that. And what's great is that exercise is the medicine, right? It's the thing. If we use this is how we can help prepare our bodies after injury for that secondary and tertiary injury prevention. And the key word is progressive resistance training. The progressive overload over time, which allows our bodies to adapt, get stronger, and helps us get back to the functional levels that we need to be at to get back to sport after we suffer injury. So with that, I just want to thank you very much. A real honor to be here, and I'm very much looking to the panel discussion.
Thank you, Dr. Jordan. Indeed, exercise is the medicine. So well put. And as far as the car, there are some days that I do feel, I feel sometimes like I'm the 21-year-old Subaru sitting in our driveway. Exercise is the medicine to try and get me closer to that Audi or that Cadillac. Anyway, next, thank you, Dr. Jordan. Next, I'd like to welcome Dr. Ranita Manocha to discuss how to safely use gait aids. Dr. Manocha is a physiatrist and a clinical assistant professor in the Division of Physical Medicine and Rehabilitation at the Cummings School of Medicine at the University of Calgary. She received her Doctor of Medicine at the University of British Columbia, then completed specialty training in physical medicine and rehabilitation and the Clinician Investigator Program at Western University, during which she obtained a Master of Science in Medical Biophysics. Dr. Manocha started the Connective Tissue Disorders Rehabilitation Clinic and the Bracing and Mobility Clinic at Foothills Medical Center. She also works clinically with patients who require nerve conduction studies and specialized wheelchair seating systems. Her research interests involve the biomechanical effects of walking aids and braces. Dr. Manocha, welcome.
Thank you. Thanks for that generous introduction and the opportunity to talk to you about my research on how to use walking aids safely. So some of you might be thinking this is an injury prevention session. Why am I talking about this? Clearly someone's already been injured, but I'm actually all about preventing that second injury. So I know for me that it's hard to do these virtual conferences and sessions. So I have a very important skill testing question to see if you're all awake and paying attention. What did Kobe Bryant, Justin Trudeau, and Sir Tom Moore all have in common? Well, at some point they all used a walking aid, like a crutch, a cane, or a walker. And we see these devices everywhere. Nearly 3 million Canadians use walking aids for long-term conditions like cerebral palsy, lower limb amputation, or spinal cord injury. And hundreds of thousands of Canadians use them every year for a temporary injury like an ankle sprain or hip replacement. Now, obviously, walking aids can have a lot of benefits. They help to offload the lower body to reduce pain or compensate for weakness. So they enable people to do things like run a marathon on crutches. They improve sensory cues. They can also improve people's balance. And they enable people to move around in an upright fashion. So that limits the risks of things like lying in bed or sitting in a wheelchair. That can cause things like muscle wasting, which we've talked a little bit about already today, or skin breakdown. But walking aids also can have potential risks. So one of the most important things that people don't realize is that walking with a walking aid actually requires quite a bit of extra attention. So this is an important consideration when we have patients who have some sort of cognitive impairment, or even people who are feeling drowsy. It does take a little bit more to pay attention. Where are you going to place your walking aid? Walking with walking aids also often takes a lot more energy than walking without one, because you're using your arms and loading them in a much more energetic way, moving your torso in a much more energetic way. So we really need to consider that in people who might have underlying heart or lung problems. Many studies have also shown that even though walking aids can improve our sensation of where things are in space, they can also increase the risk of falling. So that's through things like how it affects our attention. Sometimes when using canes or crutches, you're just making contact with the ground with a very fine point. So that can be a bit destabilizing. And some people will just trip over their walkers or their crutches. So this has been reported to lead to things like head injuries, dental fractures, skin lacerations, and sprains and strains. We also have to think about people who might just be putting weight on one leg to totally offload the other leg. And so now their good leg might be exposed to different forces or increased forces than it normally has been. And so this can cause things like knee injury or ankle injury. And the last thing to think about, and this is where a lot of my research has been done, is that using a walking aid obviously results in different forces being put through the upper body than if people aren't using walking aids. And so this can lead to extra stress on joints, bones, nerves, and blood vessels. And this can lead to injury or even just pain at the shoulder or the wrist. So we have to step back and remember that people who are using walking aids already have some form of mobility impairment. And if we add on any of these other issues, this can really affect the rest of their body. So it can worsen their function, their quality of life, and their independence. And as Lisa mentioned, I'm a physiatrist, so I'm a medical doctor that works with people with different injuries and disabilities. And I care a whole lot about quality of life and independence. And that's what makes me just so passionate about this issue. So just to give you a flavor about what kinds of upper body injuries might happen, this is a paper that we published this year on injuries reported in the scientific literature related to using crutches. And we only found about 622 injuries. And that's actually because most of these injuries don't even get reported. So unlike things like getting a pacemaker put in, if there's a problem with that, all the physicians have to report those problems to agencies like Health Canada. But when there's a problem with things like your walker or your crutch, that doesn't have to get reported by anyone. And we know this is an underreport because a study in America looking at pediatric emergency departments over a 17-year period found over 21,000 injuries coming into emergency departments related to walking aids. And that's in children. Obviously, adults use even more walking aids. So I'll just tell you about a small part of that paper where we looked at injuries related to using auxiliary crutches, and that's where most of the injuries were found. So we found about 600 injuries there. About 50% were related to that pressure from the axillary bar. So these crutches are the ones that most of us have seen in Canada. Most people get them after an ankle sprain or after knee surgery. The bar can put a lot of pressure on those structures in the armpit. So in the yellow, we see the nerves, the red is an artery, and the blue is a vein. So repetitive weight bearing through that armpit can actually cause damage. And the most common injury we found were related to permanent or temporary nerve damage in that armpit. We also found quite a few injuries causing that red artery to either stretch out or to get really narrow, and sometimes to even clot off. So that can be pretty devastating for patients. We also found a few rare injuries. So there were 8 reports of traumatic brain injury related to falling while using these crutches. 2 patients actually, because that red artery clotted off, needed to have an upper limb amputation. And we talked a bit about the energy cost of walking with walking aids. And so one patient was in hospital learning how to use the crutches, and they unfortunately suffered a heart attack, causing death just because of the amount of strain on their heart. So in that paper, we looked at risk factors for injuries, and 2 big risk factors emerged. So number 1, if people weren't properly fit with their devices, they were more prone to getting an injury. And in particular, if their crutches were too long, it caused more pressure in that armpit area. We also found that if people weren't taught how to use their crutches properly, that also increased the risk of injury. So a lot of patients hadn't been told you're not supposed to actually lean on that armpit bar when you're walking on your crutches, which a lot of people don't know. I see that all the time in my clinical practice. And so these are similar factors that have been found related to walking aid injuries with other types of walking aids, and that led me to create this app. So it's exciting. We're just kind of launching our app today to the public, but our app is called Improving Canadians' Walking Aid Learning Skills and Knowledge, or I Can Walk. And I really encourage you to check out our website to learn a bit more and download the app. But our app really helps fill a gap in how we teach patients and their caregivers, how we teach clinicians who might not know, and how we teach clinicians in training how to fit and walk with a variety of walking aids. And the app is very interactive, so it involves taking videos and doing some assessments. So I'll show you a video now, if you don't mind playing that video of how our app works. So this is an older version of the app where we only had 8 modules, but we actually have 20 now. So what the individual does is they select the kind of walking aid that they're looking at and what they want to learn, whether that's fitting or walking with it. So we'll see someone click on learning how to use auxiliary crutches and how to do a swing through gait, so not putting weight on their injured leg. And then they'll watch a video. And then they'll look at what are the components of the skill that I need to do. So they'll go through that, and then they'll end up actually taking a video of themselves or having a peer or their therapist, a clinician, caregiver take that video. And then they'll look at that video and compare side to side. And then they'll go through each of those components that were listed. So we'll take you through a few now. So they'll say, okay, am I wearing flat-soled shoes? So I think this person, when they looked at it, they said, well, there's a bit of a heel, so not quite. Are they putting the crutches about 30 centimeters in front of their good leg? In this case, they looked at it, they said yes. Maybe they were taking their time to think. But that's the nice thing about this, is it's very interactive. Now are they landing on their heel? That's pretty straightforward. Yes, they were. Are they keeping their head up? So you can see initially the individual is not, but then later on they do. So they get a bit of a partial score for that. And are they making sure to, really importantly, not lean on that bar at the top of their crutch? And they are. So the nice thing about this is it can generate discussion between a patient and their caregiver, a patient and the clinician. But the patient also gets a score at the end, so they can see what they did well, what they might need to work on. And then they can keep on taking the same module again until they feel like they've mastered it and can move on to the next one. So I'm really excited. Our app currently costs around $4, and that's just to help us cover the basic charges. But because we're launching it today to the public, we're making it free for the next 2 weeks. So I'd really encourage you to download it, give us some feedback on our website, because we really want to make this app great. And my big goal is to actually make this available to all Canadians for free in a sustainable way. So I am actually looking for a sponsor or a donor to help us out with that. I think a lot of people, if you've ever gotten crutches in an emergency room or tried to help a family member get a cane at a drugstore, a lot of times people just aren't fit with these devices properly. And I see it in my clinic all the time. It'd be nice to have something quick and easy where people can kind of teach themselves or teach each other. I also think it's really beneficial for parts of Canada that are rural or remote, where access to therapists might be a bit more limited. I've also applied for a few grants to really research, does this app actually change outcomes for patients in a variety of hospital and clinic settings, both in therapy clinics and in medical clinics. And some other research that I've done has shown that particularly nursing and pharmacy students don't get a lot of education on walking aids, how to fit them, how to use them. But these are the people that are giving walking aids in a lot of acute care settings. So can we use this app to really change their training? Can we really use this app to help nurses or pharmacists or even therapists who don't do this a lot develop their skills after they've been working through continuing professional development programs? So with that, I'd like to thank the very many team members who've helped me put this app together and do a lot of my research. And I hope that you're now just more open to think about how walking aids can potentially cause some harm if they're not used safely, and that you're motivated to help me in my lifelong quest to change that. And I look forward to answering any of your questions. Thank you.
Thank you, Dr. Manocha. What an amazing, empowering tool for people. I'm actually, as soon as our forum is over, I am calling my mom in Ontario, who has been on a walker, a cane, for the last year, as she is heading to a hip replacement later this month. So she will really appreciate that research and that tool. So thank you to you and your team providing that action item. Lastly, I would like to welcome wrestler and two-time Olympian Danielle Lappage to share her experience in sport and how she overcame injury. I mean, you can imagine wrestlers, the pounding that they take on that wrestling mat. Danielle grew up in Olds, Alberta, and was involved in many different sports growing up. She was first introduced to wrestling in 6th grade when a couple of her friends who had joined the school's wrestling team convinced her to come on and try it out. Well, safe to say, Danielle was hooked. Fast forward just 4 years later, and she had made her first national team. Since then, she's been a member of Team Canada and has represented our country at many international events. She's a former junior world champion, Commonwealth Games champion, a 10-time national champion, and Olympian. Danielle made her first Olympic team at 63 kilograms in 2015, but unfortunately, at the London Summer Games a year later, just devastation. She injured her hamstring and was forced to withdraw from the Olympic tournament. Danielle then moved to Calgary to attend law school. And while she was at law school, she continued to wrestle with the Calgary Wrestling Club. She graduated from law in April of this year, so just a few months back, and then attended the Tokyo 2021 or 2020 Olympic Games out in Japan. So currently, that's just amazing. So she just finished her law degree, and then boom, there she is competing or attending the Olympic Games in Tokyo. Currently, Danielle is articling with the BC Attorney General and was so pleased that she would be able to spend some time with us here today. So please welcome Danielle Lappage.
Hi, everybody. I'm so happy to be here. I'm so happy that I got to hear from all the brilliant doctors before me. My presentation's a little bit different. I'm just going to be talking about myself, but I hope you guys enjoy. I began wrestling when I was little, 6th grade. That's me, awkward little Danielle. That's my first tournament. As you can see, though, I was strong. I was awkwardly and abnormally strong for being a little girl. And so that strength made me quite successful right away when I first joined the sport of wrestling. And it was that early success that had me hooked. These little clip-bits or snippets that you can see are from what I call my baby books. Every year before a new school year, my mom would ask us what we wanted to be when we grew up, and she would write it down there. And you can see the first one, I think the top left one is from 2nd grade. I said I wanted to go to the Olympics. We won't talk about my failed dreams of being a TV star and singer, though. But anyway, I wrestled all the way through high school, had quite a successful high school season. And so I decided to continue wrestling at university. And so I moved to BC and wrestled for Simon Fraser University for 5 years. And those 5 years at SFU were some of the best years ever. And my wrestling career was going quite flawlessly, quite a linear progression of sport. And I was winning all of the age group tournaments that I should have been winning. So I was winning junior nationals, university nationals a few times, junior worlds. And so I saw 2016 Olympics specifically as my time to shine, my time to be successful at the games. And everything was working out the way it should be for that dream to become a reality. In 2014, I had my best season ever. I, for the first time, won senior nationals. The picture of me on the left there is me right after I won in the finals. I had beat a girl who had beat me probably 20 some times before that. And so that was a really special moment. That year, I got to go to the Commonwealth Games, I got to go to University Worlds and my first senior world championships. After that season, I took some time off and went back straight away after a couple of weeks to training again for the next season. 2015, we were going to have our Olympic trials, so it was going to be a big year. However, in November 2014, I ended up tearing my ACL. And that was a big deal to me. That was a horrible experience. It was my first big injury. It was the first time that I had to deal with an injury. It was the first time I had to deal with the possibility of not having wrestling. Unbeknown to me, I was valuing myself as a person through my performance in sport. And so this really showed me that I had to deal with that. And then also go through, the physical and emotional and mental stressors of going through an ACL rehab. 13 months later, we had our Canadian Olympic trials for the 2016 Olympic Games. So 13 months after my ACL reconstruction. And luckily for me, I was able to make it happen. I won that Olympic trials. And so this meant that I was going to go to the 2016 Olympic Games. The next 9 months after that tournament, after the Olympic trials, were the best 9 months ever. I was having the best time. I was wrestling well. I was winning most of the tournaments I was entering. And so going into Rio, I was convinced that I was going to be successful there. I was really optimistic. I was really confident. And so at the Olympics, we head to Rio. I'm the first match of the day on the tournament day. And I'm doing a warm-up that I've done hundreds of times before. And at the very end of my warm-up, my second last move, I feel pain in my left butt cheek. And I fall to the mat. I get taken to the Canadian room to get assessed. Nobody really knows what's wrong. I don't know what's wrong, but pop a couple Advil. And the next thing you know, the organizers for the Olympics are looking for me to start the day because, again, I was the first match of the day. And so I walked out onto the mat telling myself that I could do this. People, they perform with injuries all the time. And it's just, it could be an inspirational story. I walk up into the mat, shake my opponent's hand. The whistle blows. My opponent snaps my head down and I collapse. And so this picture on the right is me moments after that happened. Just don't know what's going on, what's happened. But I do know in that moment that my Olympic dream is over. I had to withdraw from that match and from the Olympic Games. And so obviously that was a horrible experience. It turns out I had ruptured my semimembranosus in my warm-up somehow. Don't really understand it to this day, but happened. And after that, I didn't know if I wanted to continue wrestling or not, or if I could even. I didn't get surgery or anything. Didn't know how it would heal. A few months later, though, in early 2017, I found out I got into law school in Calgary, and I was able to start wrestling around a little bit. And so I made the decision at that time that I wanted to make a comeback or try to at least. And so I moved to Calgary and started wrestling for the Calgary Wrestling Club. And so from 2017 to 2019, wrestling with Calgary, I had some of the best results I've ever had. Won my first senior world medal and was just having a lot of fun. In December 2019, we had the 2020 Olympic trials and I was successful there. And then in March 2020, we had the Olympic qualifier, the Pan Am qualifier. I won that tournament, which meant I was officially going to the 2020 Olympic Games. A week later, they announced that they were going to postpone the games for a year. And that was hard, but at least I would get my second chance still. So I was happy to still be qualified and that I could keep my spot, and I was going to Tokyo. In August of 2020, however, I tore my other ACL. And this was 11 months before my scheduled competition date at the 2021 Olympic Games. And so that obviously was horrible timing. I was angry, I was mad, but I made the decision that I was going to, make a comeback. And so I actually was in Calgary at this time. So I worked with all of the researchers there at CSI Calgary that Dr. Jordan was talking about earlier. And I was really proud of myself for this comeback. I was really diligent in the rehab, in all the progressions going back to wrestling. Wrestling's a really hard sport to come back from ACL because you can't really wear a metal brace. There's a lot of twisting and turning and people pulling on your knees all the time. But I did it. I made a comeback and I headed to Tokyo. At the Olympics in Tokyo, I competed against Russia in my first match. And unfortunately, I did not win that match. My knee was feeling great, but honestly, I just didn't have enough time to get kind of my timing and the feeling back. So I was not yet the wrestler I needed to be, and the wrestler I was before that injury. And just simply, I needed to be that wrestler in order to win a medal for Canada. And unfortunately, that didn't happen for me. I returned to Canada. So I'm currently in Victoria trying to get through the SPAR admissions course. But I've had a lot of time without wrestling to kind of reflect back on my experiences in sport. And unfortunately, my experiences have a lot to do with injury. And I think any athlete, any high performance athlete is going to experience some kind of injuries. But in overcoming those injuries, I changed. Each one has changed me. Each one has made me a different person. And I think a better person than I was before I experienced those things. And so today I'm thankful for that. And thank you guys. And I'm looking forward to the panel discussion.
Thank you, Danielle. And thank you so much for sharing your journey, truly one of perseverance. And we really do appreciate you spending this time with us. Wow, just to make it back to that second Olympic Games, that is really to be commended. So thank you, and good luck with your articling, and yes, passing those bar exams. Well, now we'd like to welcome all our guest presenters to the Q&A panel discussion. And I'd like to encourage you to join the discussion and ask some questions of our experts. They are happy to answer any general questions you may have, but just, and again, a friendly reminder that they are unable to offer personal medical advice. If you have a question, please submit it in the Q&A box, and we will try to do our best to answer all the questions coming through the online portal, and we will try to group similar questions together. Now, if you see a question that you like in the Q&A box, well, then you can click the like button to upvote it. And what that means is that you can then increase the chances that that question will be selected. Okay, so here we go. And this is to all presenters, so to all our experts, what is one piece of advice you would have for people who are trying to get back to their regular level of activities after the pandemic without getting injured? And maybe I'll just start with Dr. Emery. We'll start with you, Dr. Emery, and then Dr. Mohtadi.
Thank you so much. It was great to hear everybody's talk. And I guess I would start with saying that my focus has been with youth. And so many of them aren't quite athletes yet. They're sport participants, and we want them to be survivors so they can keep playing throughout their life. So I think that we have some really great evidence around neuromuscular training warm-ups. I often talk about those as the low-hanging fruit. And I think that, taking a multimodal approach and really thinking about all the different targets for prevention. And in this case, coming back post-COVID, obviously load modification is going to be a huge component for many youth athletes. And I'll pass over to my colleagues such as Matt to talk more about that, and more specifics. But I think that really that would be important to think about the combined approach.
Thank you, Dr. Emery. Dr. Mohtadi, any thoughts on that?
Yeah, very briefly, take your time, understand what you want to get back into, and try and simulate that activity as much as possible in your training, and keep it simple.
Dr. Jordan.
I'm going to just to build off the concepts here a little bit. It's interesting. I teach a class at the university on a topic about this, and I go back to a guy named Captain Thomas DeLorme. 1945, he was a physician who was helping soldiers who came back after war rehabilitate, and he came up with this notion of progressive resistance training. And really, it's like figuring out where you are on the progression. So, we often think about this as being sort of like, having to like do more than you should, or where you left off, or how I looked a year ago. And my advice would be to really, meet yourself where you are today, with where you are, with what you've been doing. Meet yourself there, and remember that your body's going to respond as you increase those loads over time. A lot of times what we'll look for is like about a 10% increase per week is kind of the type of increase that we're looking for. Now with athletes, that's often really easy to measure. It's harder when you're doing it for yourself, but that's a rule of thumb. So if you're using your your Garmin watch or your Apple Watch, you might be able to kind of look from last week to this week. Am I sort of in that rough 10% increase over time? And I think my final point would be is that your body's going to let you know. So listen to your body, and the idea that you got to push yourself to that brink, to that failure point, the evidence just doesn't support that. So you can stay in that zone of kind of like an 8 on 10, 7 on 10 effort, and it's going to do lots of good stuff for you.
Thank you, Dr. Jordan. Dr. Manocha, a piece of advice for getting back to a regular level of activity after the pandemic without getting injured?
Sure. I agree with everything that my colleague said. I'll speak from my physiatrist hat. trying to just set achievable and measurable goals. So I like to have my patients have a little exercise diary and just look at what you're doing, like Dr. Jordan said. So if you're not doing anything, then a goal might be 5 minutes of activity every day. I'd rather that you're able to do something consistently and do it every day than try to go out for an hour run when you haven't been running and hurt yourself, and just gradually progress, as my colleagues have said.
Excellent. Okay, on to question number 2. And this is for you, Dr. Jordan. How can you measure muscle strength without all the equipment?
Yeah, good question. Well, I think there are some basic things that you can do, and I'll just give a really simple suggestion. Is a lot of times where it's kind of two things. And I'll talk about the context of ACL injury. You want to have 2 strong legs, and you want those legs to be kind of close to each other in terms of their strength. So what I might suggest is that just as a part of your own training, measure your strength through the exercises that you're doing. You can measure your strength through, if we're going to a fitness facility, you're doing a leg press exercise, or you're at home and you're doing body weight exercise. You can measure your strength actually just through that exercise. It's a good way to do it. And I would also encourage you to measure on both sides to see that both sides of your body have a decent level of strength.
Very good. Okay, our next question is for Dr. Mohtadi, but some of our other experts, you may weigh in on this. It's a 2-part question. What is the new standard for recovery for a young adult, so say a teenager, after ACL surgery? So that's for the first part. And secondly, does recovery length and return to sport change after a second ACL surgery?
So very good and very difficult questions to answer. The standard of recovery is a moving target and depends upon a lot of different factors. But what we were trying to achieve is an understanding of how that person functions given the expectations they have. And we've been trying to develop an assessment tool for that, to answer that question. And nobody's really been able to have a clear-cut assessment tool to do that. So we're struggling with that. I can't give you a very specific answer, but it's a challenge. And as far as your second injury or second ACL reconstruction, which Danielle may have faced, clearly we advise people that they are at much higher risk now for everything. And as Matt put in his 2 buckets there with the red and blue balls, these are the facts that you cannot change. So I advise everybody to go slower and think about changing what they do, because they're clearly at a higher risk.
Dr. Jordan, would you like to weigh in on that, or? Yeah, I can build off this a little bit. And Danielle, I'm gonna go back to one of the things I keyed in on your presentation. Again, I don't want to put words in your mouth. This is what I heard. Hopefully it's accurate. But you sort of explained how you got back and you just didn't have enough runway, and you felt like your timing was off. Like your knee felt good, but it was like the timing, the rhythm. Sometimes in the old school boxing term, they'd call it the ring rust, right? You can't shake off that ring rust that keeps you sort of away from that. And so my advice would be that when you've got a young athlete who's coming back after an injury, it's really easy just to focus on, let's say, their knee. Is their knee okay? But I think my advice would be is to remember that these transitions are characterized by both progression and regression, which means I could be doing good and then maybe I have a setback. So we've got to accept that. And it isn't just my knee, it's my whole body. It's my timing, it's my rhythm, it's how my brain works, it's how I'm going to interpret information in a complex environment. It's my speed. It's all of these other things that sometimes we overlook. And honestly, they take time. So it takes time. We measure this in many, many, many months. It's not a 9 months and I'm good to go. That might be just where your journey starts. And then you've got a runway of another 18 months to get yourself back to what we call getting back to performance. So you got to be patient and you got to be persistent and you got to see the whole system in that process.
Very good. Thank you so much. And our next question is for Dr. Manocha. Can you comment on injuries with other walking aids, such as knee braces and walkers?
Yeah, I'd love to, but the problem is we're not capturing this information or data. So knee scooters, I've had patients who've had bursitis at their knee. Those are the ones that people are using after Achilles tendon injuries or ankle sprains. There's not really a lot of reports on that. Last year, I published a case report of someone having a stress fracture in one of their forearm bones. And it was the first case report of someone having that with auxiliary crutches. I'm sure it's happened at some point in the past 100 years, but no one's reported it. So I think there just needs to be a better system in place for tracking these injuries. And so I've kind of explored opportunities through emergency departments. Is this something that Health Canada should be tracking? I don't know what the answer is. I'm open to feedback if anyone has any ideas or looking to collaborate in that area, but I think it is important. It isn't just that first injury, it's that second injury. But certainly with knee scooters, I've seen some of that. With knee braces, I see a lot of skin problems coming from that. And then the other thing to remember with braces, there is some studies that show when you brace a certain joint, you're affecting the biomechanics of a joint sort of proximal to that or distal to that. So if you're bracing the knee, you could affect how things are moving at the hip or at the ankle, and that can affect injury risk as well. So some other things to consider.
Thank you, Dr. Manocha. Dr. Emery, this question is for you. How does your research apply to seniors exercising? Does neuromuscular training reduce injuries in seniors participating in sports? Does it reduce injuries for even non-active seniors, so reducing accidents?
Yeah, that's a great question. And certainly lots of my colleagues have asked us to collaborate in that area because there really isn't a lot of research, but there's certainly some emerging research around falls prevention and the ability to reduce the risk of injuries in older adults. And certainly the principles of neuromuscular training and would hold around things such as dynamic joint stability. And I think that even in the absence of evidence, there's certainly supporting research in youth and in young adults and in athletes that would certainly suggest that type of program would be helpful, and certainly has been helpful in the context of falls prevention, particularly things such as balance training.
Okay, great. And what is neuromuscular training exactly? This question is asking, how does this differ from stretching or yoga or fitness classes? Like, does this fit with GLAD and the UFC joint effort program?
Yeah, so that was a lot of different things there, but around things like stretching and yoga would be more of less so around some of the, certainly in yoga, there'd be more balanced training. The neuromuscular training warm-up strategies are typically inclusive of balance training exercises, agility exercises, strength training, and an aerobic component in a package really set up as a warm-up strategy. But again, components such as this are used in many different training programs and really important in a number of different contexts for sure. The GLAD program specifically is targeting individuals who have arthritis and pre-arthroplasty, and a lot of the principles around neuromuscular training are a part of many of the exercises that are part of that program as well, which is shown to be effective in delaying the surgery in many cases. So.
Great. Thank you so much, Dr. Emery. And now a question for any of our experts or all of you is, in order to prevent injuries and to rehab properly, what are the activities that you recommend to keep tissues strong and flexible? Who would like to take that? Since we're in this virtual platform, it's hard for me to just look over at you. Dr. Jordan, would you like to take that one?
Sure. Yeah.
So any activity that you would recommend to keep tissues strong and flexible?
I think so you probably already saw from my presentation that I think progressive resistance training is a great thing to put into your training. These would be things like, and it doesn't just have to be, lifting heavy things. It can be, there's lots of ways that this can be done at home. This can be done, safely. So certainly that's an element that I would strongly endorse. And I think that the science also supports that. I think that there is also a good amount of science just for, your overall work capacity. And I think this is sort of one of the tones that have come through the theme here this morning. And I love Dr. Mohtadi's envelope of function from, I don't know his first name. I know the last name is Dai, because I actually have used that many, many times in the context of sport performance to talk about kind of understanding what your envelope of function is and how do you expand that. And I think this is where, cardiovascular exercise, whether that be, the low intensity type work that we do. And, if it's safe to do so with athletes, we certainly use more high intensity methods like high intensity interval training. But building up an individual's work capacity is another key part of the puzzle. So that's a couple of perspectives from the sport performance world. And I'm curious to hear what my co-presenters have to share on this as well.
I can weigh in on that a little bit, Lisa and Matt. If we look at people who are aging, then there are 4 components that are required. So there isn't just one activity that one can do to address that question, but the 4 components would be some form of balance training, which is similar to what Carolyn has been speaking about, an understanding of flexibility or improved flexibility, some form of strengthening, and then an aerobic activity. And these would be the 4 components that certainly somebody who's aging like I am would need to include in their activity. If there was one sport that I would recommend, it would be swimming, because swimming allows you to use most of your muscles. It reduces the load on aching, injured joints. And as long as you build slowly and carefully, you're less likely to injure yourself unless you're trying to be a competitive swimmer. And they swim ridiculous loads, in my opinion. But that would be the one.
Okay, I think we'll move on now to our next question. And for this one, I think we'll ask, actually, Dr. Jordan, if we could come back to you for a quick one here on what are your thoughts on prehab?
Well, I mean, I think this might come back to, what is best practice telling us versus maybe what the science is telling us. And just to kind of orient everybody to what my definition of what prehab would be is prehab would be the stuff you do before you get hurt that hopefully keeps that next injury away. And I think there's a good amount of science to support that. For example, with our tendons grow just like our muscles do. Believe it or not, they can hypertrophy, they can get bigger. And when our tendons get bigger and stronger, they can handle more load. So there's an example of, where a prehab for your tendons to prepare your body for the marathon you're going to run and to make sure your Achilles and tendons are nice and strong and ready to go. There's examples there where certainly it's effective and I think very worth considering. And I'll just add in one more final comment here, and maybe Dr. Emery will have some thoughts. Is that this idea of neuromuscular training? A couple things, when we talk about these neuromuscular warm-ups and neuromuscular training programs, a few keys. You're doing this before your activity, right? So it's not just doing yoga at night. What we're talking about, this is something that's targeted. It's about 15 minutes long, roughly, I would say. It's often thought about in terms of what are the injuries that are in the sport. So it's very specific to preparing the body for what's about to come. And it's not there to make you super tired, right? And it's not like training like you would go to the gym and train. It's there to actually prepare your body for what's about to come. And, I don't want to steal the thunder of these injury prevention studies because, I always quote Dr. Emery, but I think conservative estimate is that it can reduce injury by 30%, roughly, spending 15 minutes. So, when we talk about prehab, I would say, absolutely, it's something I would do. And I think the science would suggest is a thumbs up. So spending some time on that before you exercise and do the things you love.
Dr. Emery, I think I'll come to you now because following up on the neuromuscular training, those protocols, can health care providers, can they use those in the community?
Yeah, I think everybody can use that in the community. We deliver some workshops that are available to coaches and teachers as well as clinicians out in the community. And I think building on some of the things that Matt said, certainly sport specificity is important. It's important to kids and their parents, and it's important to coaches. So I think that we need to think about the context in which these programs are being delivered to youth, and making sure that workshops are available for those that could deliver those programs, such as the coaches that are working with those teams every day. And I just wanted to add one other comment, and that is, it's some people believe that the notion of prevention is something, well, we need to do all of this before the season starts. And actually, the prevention program goes throughout the season. It progresses through the season. Each activity and exercise within neuromuscular training can also progress in difficulty, and that combined with thinking about training load, we really have a nice program that's specific to the sport and across multiple contexts to consider when we're thinking about keeping kids ready to participate. And that can change in different sports, and obviously will change in progression coming off COVID.
Excellent. Great intel there. Thank you. Dr. Manocha, where is there support for the proper use of a cane? Where can people access that support?
Yeah, great question. I mean, I'll give a little plug for our app. We do have skills on how to fit and walk with a cane. It's kind of hard to walk. I can walk. https:/icanwalk.info. Check it out. It's free. Yeah, that's the problem. A lot of these things aren't included when you get a cane, but if you're able to access a physical therapist or an occupational therapist, and the Red Cross also has some nice handouts on learning a bit more about how to use and walk with a cane.
Great, thank you. And now a question for our two-time Olympian, Danielle. How do you, share some of your the journey that you went through? How do you approach, other athletes to respect their bodies, and that concept of the slower return to sport? So how did you, or would you have reacted to this advice if you had received the advice of, really respect the process? You actually have to, take more time when you're just itching to get back there.
Yeah. Well, I mean, you have to follow the medical people's advice, right? And so for me, that's what I did. I wasn't wrestling's hard. Dr. Jordan was saying all the research is about ski jumpers that he's doing. And so for me, when I was talking about going back from my ACL injury, there's no real progressions to follow on the wrestling mat. And there's not very many doctors or medical people who are skilled in wrestling specifically. So for me, it was I had to make my own plan with my coach and with my surgeons. Both my surgeons actually gave me their input too. And so I was pretty confident in what I was doing just because I was, making a plan with them. But for me, again, I was on a real time crunch because of the Olympics. And so I was fast and probably too fast in my comeback. And I think that if I didn't have that Olympics, or even if I had more time to maybe try again for the next one, if I wasn't so old, maybe I would have given myself a little bit more time. But I think that, again, we know there is a way higher chance, of re-tearing your ACL after you have a first one. And we all know that, we're told that. And so I think that you just have to tell athletes that it's not just about your performance, and it's not just about medals. It's about your well-being after. And so life is more important than any sport or any medal. And I think when you're an athlete, it's kind of hard to actually understand that and believe that. But I think just encouraging athletes to really, really think about that and really understand that that's true and that's the case.
Thanks, Danielle. Well, following up on that, Dr. Emery, what sports for children would you recommend that would be good for lifelong injury-free activity of something that we might be a good one to encourage. So for those parents out there that are looking for something that maybe would be that long-term, less injury risk, what do you recommend?
Well, I'm gonna shift the question slightly because we're not going to get kids who are playing football and rugby to join the track team as a general statement, right? We want to really think carefully about getting kids playing the sports they love and as early as they can, and lifelong sport participation. So I would argue that we need to think about things such as early sport specialization. Perhaps in some sports we don't have it right. Perhaps we're specializing too early, and kids aren't getting that all-round sport experience that we used to get many years ago. I won't say how many years, but I think certainly it's important to consider multiple sport opportunities for kids and get that what some call the cross-training effect between sports. I'm a huge proponent of swimming. I still continue to be in the pool. It's the one sport that I can continue to perform at an older age, and I think that that's important to be thinking about those alternatives as we do move through the various youth and early adult years.
Very good. Thank you. Yes, the multi-sport approach. And Dr. Mohtadi, still with the youth aspect, I guess, of our discussion here, what is the youngest age? One of our participants would like to know the youngest age that you have seen an ACL tear in an athlete, youngest athlete you've come across that.
8 years old.
8. I'm in shock. Wow.
I can't emphasize enough what Carolyn just said.
Oh,
Because if you look at professional athletes, the ones that participate in multiple sports when they're young are more likely to be successful in professional sport. So it isn't just about injury prevention. It's about performance and success. And the idea of specialization at a young age is probably leading to the great increase in injuries such as ACLs that we're seeing right now. I can recall in high school and university, and my wife played varsity basketball for 5 years. And she couldn't think of somebody that she played with that had torn their ACL at that level. You can't find a varsity basketball team in Canada right now, probably without 2 or 3 women who have torn their ACLs. So I know it sounds shocking that 8 years old is the youngest, but it's all the way through all sports and young kids now. It's a big deal.
So you're seeing an increase in that then at that young age?
Not so much at that age, but certainly what happens is that the young kids are able to adapt. The teenagers are not. And so it's the teenagers and the young adults where we're seeing the highest risk of ACL injury in particular. And I'm sure Carolyn would give you a lot of stats on all of the other injuries too, which, well, concussion, of course, we heard about.
Mm-hmm. Thank you, Dr. Mohtadi. And actually, I'm going to stay with you, and then maybe Dr. Jordan, if you can also follow up after Dr. Mohtadi. Many people are wondering what is the best way to recover from a knee or hip replacement? Dr. Mohtadi.
Well, let's go back to the prehab question, because my interpretation of prehab is preparing yourself before surgery. And so the best way to recover is to be prepared before you go in. And it's so important for this type of surgery, whether it's weight loss, whether it's strengthening, whether it's understanding what you need to go through afterwards. So I think for hip and knee replacement, the GLAD program that might allow you to delay that procedure, number one, and the strict prehab before surgery, number two, will allow you to recover much better after those operations.
Dr. Jordan?
Yeah, no, full disclosure, this is completely out of my scope. But I'll just maybe, piggyback off of what Dr. Mohtadi's saying from the standpoint of if there's anything we can draw from the world of sport performance, where athletes go in for a big surgery like an ACL reconstruction, and what again I think practice suggests, and what we see in the science, is that it absolutely has a big bearing. What you go in with, what you go in with in terms of your strength and your function before something like that has pronounced effects on how you do after. And so I can echo that whether it's probably a good generalizable rule, to get yourself as strong and physically prepared as possible for a hip replacement or a knee replacement, and be ready for all that entails.
Thank you very much. Our next question is for Danielle. Can you share more about your experience with both the physical and mental recovery? Do you have any resources that you would suggest for athletes to prevent injury or return from injury? So is there anything that you could share in that respect?
Obviously, I haven't been able to prevent my own injuries very well, but in terms of coming back from injuries, I think that I don't want to talk for other people, but probably every athlete, the hardest part is not the physical part of coming back. It's the mental and emotional part of coming back from a major injury, especially if you're in sport, because, you're missing out on practicing, going to tournaments and doing what you love and being around people that you love. And so I think it's just, listen to your doctors, listen to your physiotherapists, do the work, do the physical work, but also do the mental work. Continue to, seek help when you need it. There's a sport performance or psychiatrist or psychologist. I've had to, use those kind of resources myself, all the three injuries that I've talked about. So yeah, I think just doing what they tell you, listening to your body, and knowing that it's not going to be a linear recovery process. You're going to face some setbacks no matter who you are or what the injury is, but you're going to come out the other side. And as long as you, listen and do the work.
Thank you. Well, this is one I like this question because it's been on my mind as well. Here we are, Dr. Jordan. We hear from money-making corporations such as Fitbit how many daily steps that we should take. Is the standard being 10,000. Is this based on any science, particularly for aging or injured folks? How many steps per day is ideal for someone over 50? And what about for other age ranges? I mean, is 10,000, is that the benchmark, or is that a Fitbit benchmark? Can you give us some insight into that, please?
Yeah, no, I'm afraid that the science underpinning that notion is equivocal. Let's just say, I mean, what there's evidence for, and I think Dr. Manocha kind of nailed this one, right? Is being consistent with what you can do, and the evidence is there for the consistency. That it doesn't have to be, to get benefits. It doesn't have to be that I put in the 10,000 steps. I did the 10-kilometer walk. I did the 6-hour workout. This idea of small, frequent dosing of exercise has a really big, pronounced effect on our longevity. And yeah, certainly the 10,000 steps is not something that I necessarily think a tree that we're putting our ladder against, so to speak. But let's look at some recent evidence that's come up about the importance of standing up during the day if you work at a desk. Like literally getting up and moving around and not sitting there. Those things have big effects on our health. So I might shift away from the lofty goal of 10,000 steps to starting to do more measurable, manageable, small things. Small things make a difference. So that would be my view on that.
Very good. Thank you. Consistent with your steps. Okay, well, let's see, I have 3 here in front of me, and this will be, I guess, our last question. Okay. Dr. Emery, can you talk about, the higher risk for injury or re-injury after an initial injury? Does it apply to other injuries? So in this case, they're wondering about plantar fasciitis.
Yeah, I'd say that there's certainly quite a bit of evidence across multiple injury types and irrespective of injury type that leads to greater risk of injury or a second injury. So, for example, even in the concussion literature, those that have had a previous concussion seem to be at a greater risk of a musculoskeletal injury to follow for a lot of different reasons that may relate to being prepared to return to play. And so I think that we need to think about the rehabilitation following an injury for secondary prevention of recurrent injury in a similar way to thinking about preventing the first injury for sure.
Okay, great. We have time for just a quick follow-up. Is it important to vary the exercises in your neuromuscular prehab routine from time to time, or is it okay to use the same sequence before games and practices?
Well, I think it depends on what you're using it for and at what level of play. So there's a lot of different components there for sure. But arguably having components that across those four areas has been described within neuromuscular training and as Dr. Mohtadi spoke about as well is really important. And progression throughout the season is important as well. So I think it's about not just doing one thing and really being prepared to participate and thinking about it from that context as well.
Very good. Well, thank you so much to all of our presenters today as we are going to now wrap up the 2021 Wood Forum. And we want to especially thank all of you for attending today's event, and a very extra special thanks to Dr. Donna Wood and her family and the Wood Joint Research Fund for the ongoing support that allows us to continue these great public events. Now, if you would like to learn more about how you can support this and other cutting-edge research that takes place at the McCaig Institute for Bone and Joint Health, please contact the Institute at mccaig@ucalgary.ca. Lastly, you will all receive an online survey in the next few days about our event, so please do fill it out. We would greatly appreciate the feedback. So thank you again so much on behalf of everyone on our panel, all of the organizers for this event. I want to thank you so much for joining us, and to quote Dr. Jordan from earlier in our discussion today, exercise is the medicine, my friends. Exercise is the medicine. So I hope you have a great rest of your weekend and enjoy the sunshine wherever you are. Thank you. Bye-bye.